Hello, and welcome to this lecture for the Chrysalis Professional Diploma in Therapeutic Counselling Practice. This is component 4, Understanding Depression and Human Relationships. And this is module 4. And in this module, we will be looking today at depression. You can find the standards met by this particular component outlined in Moodle and in your written course materials. I will share some slides with you throughout this lecture, and you'll be able to view and download these slides from Moodle as well if you want to. Please note any questions you might have as you are watching this lecture, and take these questions to class to discuss with your class tutor. So it affects all genders, social groups and ages. There isn't really anybody who can't get depression. The statistics show that up to 22% of people in the UK will be affected, with 16% prescribed antidepressants. And formal diagnosis is through assessment tools. So the DSM-5, the ICD-11, the BDI, Core-10 and PHQ-9, and I'll talk more about them a bit later. There's no blood test or physical test that can be used to diagnose depression. And we're now moving away from the endogenous and exogenous distinctions. So previously, these were used to describe whether the depression was from an internal source or caused by external events. But there's now a move away from doing that. So in some cases, the trigger for the depression will be clear, and it's often related to loss, some form of loss. And we know, if you think back to the grief curve, we know that the bottom part of that grief curve was depression. For some people going through grief, they will just reach a low point. For others, they will go into a full depression. In other cases, depression might come from hormonal changes, or we know in postnatal depression and seasonal adjustment disorders that there's things happening in the environment that are causing those. So there's many variables, both biological and psychological. And we need to view our client as a unique individual, having a unique experience, and provide support the best way we can to that individual. So a diagnosis of depression is not necessarily the same as the experience of depression, because many clients will arrive at therapy without a formal diagnosis, but experiencing symptoms of depression. And the diagnosis of depression is difficult. It can be a complex process. And obviously, as therapists, we do not diagnose, but we do need to recognise symptoms of depression in order to assess how we can help a client, or even if we can help a client, or if it's outside of our competence and confidence levels. So mental health practitioners use the DSM, the Diagnostic Manual of Mental Health Disorders, and it uses that to diagnose. So that lists various symptoms that apply to different types of depression, as well as all the other mental health illnesses. And there's also the International Classification of Diseases, or the ICD, and they're used alongside diagnostic tools such as the Beck Depression Inventory, the CORE-10, and the PHQ-9. And these are all tools which ask a client a number of questions to assess the level of distress present and the severity and frequency. And while they're very useful, I've used some of these tools myself, they are really only a guide, because it depends on the client's mood when they're answering the questions, and their mood might change from day to day and even throughout the day. So we can't just use those tools, we need more information than that. So counselling seeks to understand the individual's story and what has led them to their current feelings and thoughts, and discuss their experience and their distress. So clinical depression is different to feelings of just being down. And we all probably feel down from time to time, depending on what's happening in our world and what mood we're in. Feelings of guilt and the need to end life due to an overwhelming sense of worthlessness will be combined with difficulties with cognitive processes and being unable to feel pleasure in any activity that was previously enjoyed. So there's certain criteria that somebody has to meet to be diagnosed with depression. But how a person experiences it will be individual to them, and symptoms can increase or decrease in severity and number. And symptoms will also depend on the environment the person is in, and also the support network that they've got around them. So let's look at some of the categories. And there's 8 specific disorders in the DSM-5. So I'll just go through these. So disruptive mood dysregulation disorder. And this is a diagnosis for children under 12 who've previously been diagnosed with bipolar. And I think these are relatively new changes. And of course, we've got bipolar that's diagnosed in adults. Major depressive disorder, persistent depressive disorder, where it lasts longer than 2 years, premenstrual dysphoric disorder, substance medication induced depressive disorder due to another medical condition. So that can be depression that's a side effect of the medical condition they've got, or of the medications that they're taking for that condition. Other specified depressive disorder and unspecified depressive disorder. And attention is given to the duration, timing, and presumed underlying causes, with a new focus on levels of severity. So let's look at some of the symptoms that go along with those different forms of depression. So on the left here, we've got the criteria from the DSM-5. So to be diagnosed, somebody would need to present with a depressed mood and loss of interest, and also change in appetite, energy, sleep, concentration, feeling agitated or worthless, and possible suicidal thoughts. But other symptoms that someone might have are headaches, stomach aches, general aches and pains. So there'll be physical symptoms. They may experience a lack of energy and fatigue, and there might be alterations in their eating. So they might be eating too much or too little, and the same with sleep. They might be sleeping too much or too little. There'll be behavioural symptoms. So there'll be maybe reduced interest in normal activities, and they'll get less enjoyment from those. and reduced ability and difficulty concentrating, and difficulty making decisions, and they may neglect their responsibility. They may neglect their personal appearance. And then there'll also be emotional and cognitive symptoms. So feeling irritable, feeling apathetic, hopeless, negative, guilty, anxious. And they may have strong negative thoughts in relation to themselves, others, or the world. They may feel worthless and feel that life has got no point, and so they may be having suicidal thoughts as well. There does seem to be some genetic and biological links, but past and current traumas and environmental stressors also play their part. We know that depression, and especially bipolar, can run in families, and studies of twins also confirm that. But we also have to think about the possibility of learned behaviour as well as genetics, because somebody who is around two depressed parents could easily learn that behaviour. So it might be hard to tell whether something is genetic or learned. Now, the diathesis stress model of depression observed that depression has a tendency to be inherited, yet also shows a significant relationship to life stressors. So diathesis means a vulnerability or a predisposition to developing depression. And it argues that depression emerges from a combination of stress alongside this predisposition towards it, and that neither the predisposition or the stress is enough alone to produce the depression, that it views that stress activates the predisposition or the diathesis, which then leads to the depression. So let's just look at that. So this is the diathesis stress dual risk model. So you can see here the environment and the experience of the person and the outcome, and how somebody who is predisposed to depression, that's experiencing stressful events, is more likely to get depression, whereas a resilient individual, somebody who has good coping mechanisms and deals with their stressors well, they're less likely to experience depression. Often a first response to a person reporting depression to a GP is medication. So they prescribed antidepressant medication. And pharmaceutical companies have strong evidence that for the majority of people, medications are helpful, although other evidence suggests that the effects are little and sometimes no more than a placebo. And of course, medication doesn't help get to the root cause of the depression. There's a lot of evidence that shows that psychological intervention is effective in helping individuals that are experiencing depression, whether or not they're taking medication as well. And in the UK, talking therapies play a large role in the treatment of depression. But for some people, taking medication, even if it has effects because of the placebo, it can help them reach a point where they can tackle the resolution of traumas from the past that have affected their lives. So, you know, although maybe medication is overprescribed at times, for some people it can be useful. And we need to think about ethical considerations here. We don't know as therapists about medication, and we should never advise our clients on anything to do with medication. So if they don't want to take it, or if they think it's not working, if they think their dose is too high or low, or it's having a negative impact on them, we need to refer them back to the GP rather than get into any discussions about it. And as sessions progress, it's important that we continue to monitor a client's emotional state. And if we think they're getting worse or they're displaying any physical symptoms, then we need to refer them to their GP. So let's look at the treatment in the UK. So step 1 at the bottom here, all known and suspected presentations of depression. There should be assessment, support, psychoeducation, active monitoring and referral for further assessment and interventions. Step 2, where there's persistent depressive symptoms or mild to moderate depression, then there should be low intensity psychosocial interventions, psychological interventions, medication and referral for further assessment and interventions. Step 3, persistent depressive symptoms or mild to moderate depression with inadequate response to initial interventions or moderate and severe depression, then the nature of that intervention is medication, high intensity psychological interventions, combined treatments, collaborative care and referral for further assessment and interventions. And step 4, for severe and complex depression, risk to life and severe self-neglect, then medication, high-intensity psychological intervention, electroconvulsive therapy, crisis service and multi-professional teams and inpatient care. Now, while this is all very nice and looks good, I'm personally not convinced that it happens as it should. The frontline treatment for depression is CBT, and referral for CBT can usually be from a CBT therapist, referral from the GP to a CBT therapist, or sometimes a course of online CBT, which may suit some people and not others. And for many patients, the waiting list will be long to see a CBT therapist. The client might not feel that CBT is right for them. And also they might not respond well to medication. GPs are often happy to refer clients to counselling, and often clients will self-refer rather than wait on a long list. Or they may have tried medication or CBT online course and decide that that's not helpful, I want to see a therapist, and so self-refer. And of course, we might get clients who present with other issues where we recognise that depression might be present. And we need to always be looking out for that. So we must remember that clients present with all sorts of presenting issues, but there may be underlying issues like depression or anxiety. So taking a pluralistic approach ensures that we take a curious and open-minded attitude to how the client defines his or her problems. And depression can often exist alongside anxiety and previous trauma, and also long-term health issues and pain, and also self-defeating behaviours such as substance abuse. So we really need to look at the whole person and all the issues in their life. And building rapport through the use of the core conditions and developing understanding, assisting the client to break down goals into smaller goals, can assist the client towards change. And the client can often feel stuck at the beginning of therapy. So we need small steps. The trouble is with when we're working with a client with CBT, there's disadvantages which we'll go into shortly. But let's first look at some of the factors that can affect client and increase the chances of experiencing depression. So a history of relationship problems, and that could be the cause of the depression or an effect of the depression, and that can relate to unresolved issues from the past. So stressful events, especially bereavement and any type of loss, but also difficulties at work or financial and health issues. So anything that's stressful, especially if there's lots of different stress going on, then that can increase the chances of experiencing depression. Chronic and acute illness can trigger depression. And somebody being in pain all the time with a condition can cause depression. Personality obviously plays a part. We know that people who are half glass empty, who are more on the negative thinking side, a bit pessimistic, are more likely to increase depression. That is likely to increase their chances of experiencing depression. Drugs and alcohol dependency. Often people use some sort of drug or alcohol to numb their emotional pain. And when they're feeling depressed, they think that's going to help them. But actually, some of these drugs and the alcohol are depressants. And therefore, in the long term, it just makes the depression worse. And family history. So we know that someone who has a parent who has depression, they're 8 times more likely to experience depression themselves. And again, it's hard to say if that is genetic or learned or a combination. So it's important to also look at things that buffer someone against depression. So these are all things that can help us to not develop depression. So strong supportive relationships. Having a strong support group where the person is able to talk about their feelings and feel heard. Meaningful and regular employment. And again, that goes along with having a purpose in life. People need a purpose. A healthy diet, good quality sleep and regular exercise. So having a healthy lifestyle. And again, as I said, that strong sense of purpose. An ability to live more in the moment rather than feeling stuck in the past or feeling anxiety about the future. Anxiety and depression often go together. And if people were more mindful and more in the present moment, rather than going back to stressful events from the past or worrying about what's going to happen in the future, then they'd be less likely to experience the depression. So that ability to live in the moment is really powerful. An ability to develop helpful coping strategies for stressful situations. including identifying triggers towards depression. So if we've got good coping strategies, if we've learned those, and we deal with stressful situations well, going back to that diathesis stress model, then we're less likely to experience depression. And if we can identify our triggers towards depression, especially if somebody's had depression before, if they can learn about their triggers and catch it early, then they're more likely to prevent themselves going into a deeper depression. And an ability to identify and deal with internal stressors that might be operating within the individual. So this sort of goes back to coping mechanisms. If we can identify, excuse me, if we can identify early those that we're feeling stressed and we can do something about it, then we're less likely to experience depression. So let's move on then to look at how CBT and person-centered view and work with depression. So as I said, CBT is the frontline treatment. That's the go-to treatment for medical professionals referring to a CBT therapist or online course. And as I said earlier, there are disadvantages to CBT. So how CBT views depression. So the cognitive triad of negative automatic thinking, negative self-schemas, and errors of logic or faulty information processing. So CBT views depression due to these factors. So the cognitive triad of negative automatic thinking is the diagram below. So this person is likely to have negative views of the self, negative views of the world, and negative views of the future. And obviously they've got a negative schema, self-schema. And they've got errors of logic. They would have had negative experiences in the past that has led to this way of thinking. So with CBT, we're looking at the faulty beliefs and thinking that is based on past experiences, not current situations. And we're challenging those faulty beliefs and thoughts. However, when somebody is really depressed, they often can't think straight and they're often very unmotivated as well. So giving them a CBT form to work through at home is probably not going to be the best idea. They just might not be motivated enough to do it. They might not be able to think properly. Also, the medications that they might be taking can also muddle their thinking. They can sometimes make somebody feel numb. So doing CBT and actually thinking about their own thinking and challenging it can be really difficult. Behavioural type interventions can be useful, such as getting some gentle, regular exercise and getting out in nature and practicing mindfulness and establishing positive routines. But again, when people are feeling really low, sometimes even doing those things are really, really difficult. And trying to keep their thinking in the moment can be difficult. Trying to get themselves out just for a short walk can be difficult. So with milder depression, some of these things can work really well, but with a more severe depression, it can be very difficult. Of course, with our pluralistic approach, we need to use CBT at the appropriate time. And that will be after we've done our initial assessment and case formulation, after we've built rapport, after we've listened to the client's story and their thoughts and feelings and gained understanding of their situation. And empathy is vital. And we also need to go slowly, not expecting too much progress and only setting small goals. So clearly, using a pluralistic approach, we would firstly use person-centered therapy to build that rapport and trust from the client and listen to them. So let's look at how person-centered therapy views depression. So person-centered sees it as an incongruence in the depressed individual. There's a discrepancy between the real self and the ideal self, or the actual self and the self they think they ought to be. And you can see that below, you know, there's going to be conflict within the person. So we need to examine the client's self-concept and conditions of worth. So you should remember all this from the person-centered work, the self-concept and conditions of worth. So how they view themselves, how they've had conditions of worth put upon them by other people in their lives. And we need to use the core conditions and provide a safe, supportive relationship, because that will benefit the client and that they'll feel they can open up to us. And in exploring the client's world, we may find distressing intrapersonal processes where one aspect is overly critical of another. So the client's actual self may be very different to the ideal self. Maybe they put pressure on themselves to be this ideal person. The actual self and the self they think they ought to be, usually based on other people's views and beliefs. Maybe they had a lot of pressure put on them in their younger years and learned they weren't good enough. So they're always trying to be more than they are or live up to other people's expectations rather than be true to themselves. So the client's present will indicate the severity of the depression and their motivation to change. And of course, when we're discussing some of this with the client, we will also be going back to the past and looking at past situations and unconscious conflicts. So we'll be also using psychodynamic therapy. The traumas that have happened to a person will have a big bearing on the extent and frequency of their depression. So having a good idea of all the things in their past that have caused them stress and sadness will give you a picture of how the present situation has come to be. And a timeline can be really helpful there. You know, these issues may need discussing and working through. There could be unresolved loss or a build-up of stressful or traumatic events. There could be abuse from childhood. There could be a history of unsuccessful relationships and many more situations that may have caused the depressed state. And of course, also looking at the past will give us an insight into any possible genetic tendencies and also learned behaviours. But of course, we need to be careful when we're going into the past, because taking someone back to past traumatic events when they're depressed can make the depression worse. So timing is really important here. The client needs to be ready to look at previous issues. So that's how CBT and person-centred views depression, and how we would use those alongside with psychodynamic in our pluralistic approach. Now, let's now move on to look at risk assessment, because a lot of people with depression have suicidal thoughts and could be at risk of harm. So the legal responsibility towards a suicidal client who intends to harm themselves is rather complicated, but you do have a moral duty to keep a client safe. So the NCS, in its current code of ethics, talks about responding appropriately to clients at risk of suicide or serious self-harm. So let's look at this, because it is quite complicated. So responding appropriately to suicidal clients creates one of the most challenging situations encountered for counsellors. As there is no general duty to rescue in British law, counsellors need to be explicit about reserving the power to breach confidentiality for a suicidal adult client. To do so without explicit agreement may constitute an actionable breach of confidence. A therapist who knows that a client is likely to harm himself or others, but who will not give consent for referral, must carefully consider the ethics of going against the client's known wishes, and also the possible consequences for their client of either referral or non-referral. So it is quite complex here. So things you need to ask yourself and talk about in supervision is, what has the client given me permission to do? Does that permission include referral? If I refer, what is likely to happen? If I don't refer, what is likely to happen? Do the likely consequences of non-referral include serious harm to the client or others? Are these likely consequences preventable? Is there anything I or anyone else can do to prevent serious harm? What steps would need to be taken? How could the client be helped to accept the proposed action? Does my client have the mental capacity to give explicit informed consent at this moment in time? If the client does not have mental capacity, then what are my professional responsibilities to the client and in the public interest? If the client has mental capacity but does not consent to my proposed action, what is the legal situation if I go ahead and do it anyway? So that probably seems like an awful lot to think about. Now, it's really important at the beginning of therapy, when you have your initial consultation and you do your contract, that you're very clear with a client when you will breach confidentiality. And hopefully a client will give you permission to contact somebody else if they are having suicidal ideas. But what if somebody comes and they're not suicidal at the beginning of therapy, and they give you that permission, but then later on in therapy they do become suicidal? And when you say you're going to contact their GP or their partner, they decide they don't want you to. And that can easily break the trust and rapport, and could even end the relationship between you and your client. And you've got to assess the risks to your client, to other people, yourself, and also try and assess, is this client in their right state of mind at the moment, or do they need to be sectioned because they're really not in their right state of mind? Who do I need to contact? What are the consequences if I don't do anything? What are the consequences if I do? There's a lot of questions that you need to ask yourself and really think about. But of course, your first port of call is your supervisor. And we'll go on to look more at this. But ongoing risk assessment throughout therapy is really important because, as I said, somebody might not be suicidal at the beginning of therapy, but become suicidal. Or somebody might be very suicidal at the beginning and get better, but somebody might have suicidal thoughts at the beginning, but no intention to carry them out. But then later on, maybe they get further ideas about carrying it out. So we really need to be assessing throughout the therapy process. And we can't assume that a client who says they're not having suicidal intentions at the start of therapy will not have them later on. So many therapists put together a suicide plan with their clients if they're challenged by suicidal ideation. And that plan states what the client can do immediately, such as who they can contact for immediate help. So steps that you might take. So, as I said, making sure that you have a contract stating when to breach confidentiality. And of course, your first port of call is your supervisor. Now, in your placements, organisational policy will determine what is considered appropriate or not, and you have to adhere to that. So in your placement, you will probably be asked to read all their policies and procedures. Now, service providers have strict regulations regarding contact with clients between sessions, and your organisation might have that in their policy and procedures. So it would be inappropriate to discuss with your client being able to call you if they were distressed, for instance. You might not be able to do that in your placement, whereas a counsellor in private practice might decide that the client could call them if they were in distress. You might be aware that the person may have extreme suicidal feelings, but not at the moment intend to harm themselves, and often it is a cry for help, but we can't assume that it's just a cry for help. And a client might agree that we can contact their GP if they're feeling suicidal, but we may need to call an ambulance or police in an emergency. And we need to, of course, tell the client that we are obliged to tell the relevant authorities. But as I said, it can be distressing for the client and they may not want you to do that. So the type of action that you take will depend on the client's individual circumstances. And we must always follow the relevant code of ethics for our own safety and the safety of the client. And as I said, your supervisor is your first port of call. So you're not having to deal with this on your own. You've got a supervisor for that reason. And in your organisation, you might also have a practice manager that you can go to. if your supervisor isn't available. But of course, sometimes you might feel that someone is in immediate danger and you have to deal with it straight away, because leaving it would cause harm. And we'll look at some of there's some factors here that might increase the risk, but we've got a whole another page on that in just a second. And possible signs that someone is intending to commit suicide as suicidal thoughts, but those on their own don't necessarily mean that client's going to do that, but showing serious intent, previous suicide attempts, so if they've done it once, we know they can do it again, a history of mental health issues, a family history of suicide, and a history of an abuse are all signs that we really need to take seriously, that this person could be at real risk. And the Samaritans are a charity that offer round-the-clock emotional telephone support. And if we think our client is at risk, it would be a good idea to give them the number for the Samaritans. So factors that may increase the risk of suicide: social problems, family stress, separation or divorce, social isolation, bereavement, and especially multiple losses, mental and physical illness, and access to a means of committing suicide, alcohol and drug use, unemployment, some types of employment. There's some types of employment that we know increase the risk of suicide. Race, young people, young lesbian and homosexual men seem to be at higher risk. And it's also found that 1 in 4 people who commit suicide were found to have been in contact with mental health services in the year before their death. And schizophrenia and bipolar are heavily linked with the risk of suicide. So, of course, these are all things that we need to find out from our client, all questions we need to ask, so that we can limit that risk as much as possible. And in your placements, you may use some of the assessment tools that I talked about earlier. They may use them. They may not. In private practice, you can choose to use them. And as I say, they are very useful, but they're an indication. We shouldn't base everything on just those tools. It would be good for you to do the Chrysalis Suicide Awareness course, which is available to all students. So yeah, think about doing that if you haven't already. Men are sadly 4 times more likely to kill themselves than women, and it's the most common cause of death in 15 to 44-year-old men. And maybe that's because men aren't as good at talking about their problems, talking about their feelings. Men don't really go to the pub and start talking about their feelings like women often do. And also, men are supposed to be the strong ones. They're supposed to be able to cope with stuff. I think those beliefs are changing now, but certainly in older men, you know, they had those beliefs. Women attempt suicide more than men, but they don't succeed. So maybe with women, they're trying to have that cry for help. Maybe their intention isn't really to kill themselves, it's to get the help they need. So as a therapist, You know, if a person is having suicidal thoughts, you can't avoid it. They may feel that they can talk to you, and it can be a scary subject, especially when you're training or you're newly qualified. But it's really important to listen, to not avoid the conversation. But as I say, it can feel a little scary. But just because someone is experiencing suicidal thoughts, as I said, it doesn't mean they're going to carry them out. But we do have to take everything seriously. And so we need to assess the risk. The majority of clients are in therapy because they want help. That's why they've come to us, because they want help with their problems. So remember to make sure you know what your current placement organisation's policies and procedures are around this issue. The main thing is to talk about it. And some of the questions you can ask a client to get a better idea of their real thoughts are: how often do you think about suicide? Do you really want to end your life, or do you just want the emotional pain to stop? Are you trying to escape? Do you think you can be helped? Have you got a reason for living? Who is here? What is your purpose that makes you want to go on in the world? How would you do it? Have you thought about how you would do it? Have you got a real plan? And if somebody has actually got a plan, then they are probably serious about doing it. So there's some really useful questions to ask. And obviously you can then talk about all this with your supervisor, which will hopefully put your own mind at rest a bit more. And you can't give people suicidal thoughts or intentions by talking about suicide. Generally, by bringing things into the open and letting people talk about it and offload their feelings, then it makes them feel better and they feel that there's hope. So never be worried about talking about suicide. Okay, so that's been a lot of information for you to take in today. Let's finish then by just looking at ethical issues, the law and good practice, because this is always an important factor as part of this course. So just a reminder of the key aspects of working ethically. Respecting culture, values, beliefs, experiences and feelings of the client. And we're using the core conditions. We're being empathic, we're being congruent, and we're giving unconditional positive regard. And the client hopefully experiences all that from us. It's about recognising the sensitivity of client issues and keeping that confidentiality, except for supervision or when we need to disclose things because of laws, or because we're subpoenaed in court, or because of harm to a client or other people. We need to remember to keep clear professional boundaries and working within our level of competence and keeping our contractual obligations. And we also need to always be working on our own self-awareness, being aware of our own motivations for doing this work, understanding our own limitations, thinking about our skills and our knowledge, and when we need to refer on, and making sure we always have appropriate supervision. So let's finish by reminding ourselves, just recapping on what we've learned today. So we looked at the various types of depression and symptoms of depression. We looked at how treatment should work in the UK and how we talked a little bit about medication. And then we looked at person-centred and CBT and how they view depression and work with depression. And then we looked at the possible risks of somebody presenting with depression. And we talked about risk assessment tools and diagnosis. And we talked about assessing and monitoring suicidal risks. So lots to think about. Make sure you read the module notes thoroughly. And obviously when you have your session with your tutor, you will gain a better understanding of all this, because you can have certain points clarified and ask lots of questions. So that is it for me for now. Let me stop sharing this screen with you. And I will see you again soon at another module. Bye for now.